Welcome everyone to our 40th webinar. I'm Niti Daftari from the Circle of Cleft Professionals. Today we have Dr. Leonardo Feitosa, who's joining us from Brazil, who will be discussing with us the results of a study on fistula rates and aesthetic outcomes after two-stage palate repairs. We will be having simultaneous interpretation in Spanish for the entire duration of this webinar, for which we have Ben and Eva, who've joined us from Chile. At the bottom of your screen, you will see an interpretation button. If you would like to hear the rest of this webinar in Spanish, please click on the button and select Spanish. If you would like to continue in English, we recommend that you select English. It would help enable any Spanish to English translation that could take place during the discussion. If your bandwidth allows, please keep your video on. Use chat to introduce yourself to the group and tell us where you're from. Please display your full name on the screen. During the presentation or discussion, feel free to type in your questions or comments or to use the reactions button. You will be muted during the presentation. If you would like to speak during the discussion, you can get our attention by using the raise hand feature on Zoom. Our agenda for today's hour-long webinar: we will begin with a quick COCP update, followed by a presentation by Dr. Leonardo Feitosa for the first half hour. This will then be followed by questions and discussion for the remaining half hour. We have three core objectives at the COCP. Our aim is to facilitate networking and collaboration amongst cleft professionals, to communicate the growth and impact and learning that's happening within cleft care, and to support the growth of local teams in implementing comprehensive care. We are a network of over 700 multidisciplinary cleft professionals from over 80 countries spread across the globe. A shout out to these 11 international charity organizations, all of who have come together to make the COCP and all of its activities possible. Over to you, Hugh, to introduce our presenter for today.
Thank you, Niti. I am delighted to be here. We've taken a bit of a break, but I wish you a very good morning, good afternoon, or good evening. As you'll see in the chat as it scrolls by, we are truly a global gathering this morning of people committed to really excellent cleft care, especially in resource-constrained situations. And it is my pleasure to introduce to you Dr. Leonardo Feitosa. We're just starting to get to know one another, and wow, there is a lot going on in terms of his own context as a cleft surgeon, and also in terms of the commitment to a team-based multidisciplinary approach in a place, in a region in Brazil that does have some resource constraints of its own. So we know that the best repair technique for each cleft palate case is a challenge, and it's not something that just is of interest to surgeons on this call. It's interest of everyone, because having a safe, effective, and timely repair is one of the key foundations for everything else that we'll build upon in terms of seeing children overcome the limitations of cleft in their lives and achieving full rehabilitation. So this is an amazing topic. It's one we haven't focused on for a while, and I'm delighted to have Dr. Leonardo Feitosa to lead us through the next 25 minutes or so we can have an excellent conversation about how this type of research applies in our very own context. So Dr. Feitosa, as you can see, he's a medical doctor. He has a PhD. He's a plastic and craniofacial surgeon at the Sabin Children's Hospital in Fortaleza, and he's a full member of the Society of Plastic Surgeons in Brazil. He's also a Smile Train partner, and we're delighted to have you with us. Without further ado, Dr. Leonardo, please, welcome to the COCP webinar, our 40th one, and do feel free to share your screen and lead us through what you've prepared for us today. The anxious moments as the tech, does it work? Does it work? Yes, it works.
Good morning, everybody. Good afternoon. Good evening. I'm Leonardo Feitosa. Thank you for the introduce myself, Heath. And today, initially, I would like to thank you, mainly Niti, for getting in contact with me many times. I'm sorry about the delay of some emails. I would like to say there's a unique opportunity to be here, and I'm really glad discussing about the subject that I love a lot, cleft lip and palate.
And just Dr. Leonardo, we're seeing through your presenter view, so if you hit that little play button, then we'll get the full picture for our screen.
Okay, just a second.
I think that one right there will solve it.
Is it okay?
Perfecto.
Okay, sorry. Oops. Just a second. Okay. So today we're talking about fistula rates and aesthetic outcomes after two-stage palate repairs. My name is Leonardo Feitosa. I'm from Brazil. Nowadays, I'm in Fortaleza, northeast of Brazil. And okay, I have no conflict of interest in relation to this presentation, but you can see the Smile Train logo in many pictures because I'm a Smile Train partner here in Brazil, trying to work and solve some huge problems that we have with people with cleft lip and palate. I would like to start my presentation with this lovely picture of, they used to be my crew a few years ago. Here you can see those two girls and two boys. They were fellows studying cleft lip and palate in Centrinho, Bauru. It's one of the most important hospitals dealing with cleft lip and palate and craniofacial anomalies in Brazil. Here you can also see this little girl here, a friend of mine, Karina. She was a resident of craniofacial surgery. I was a resident there and also a fellow for a few years. And those two guys, Dr. Nivaldo Alonso and Dr. Cristiano Tonello, they are amazing surgeons, craniofacial surgeons. And I'm really thankful for them because they taught me almost everything that I know about craniofacial surgery. So while I was there, I learned a lot at this hospital during those years. So I always thought, how could I give something back in return for everything that I learned, for everything that they gave me, and show part of my gratitude. So it was when that I thought I started a kind of an internal audit. I was talking with Dr. Cristiano Tonello. He was the director of the hospital at that time. And then I started a long process of reviewing medical records, and that could be used for possible changes as the hospital. Because, we've been working so hard. We give a lot of time. We do a lot of surgeries, taking care of patients, but we usually don't stop to see what we are really doing, to check our patients, to review our results. And that's the most important fact that I bring for you today, not only for a specific technique or something like this. The fact is that it can often be a challenge for the surgeon to choose the best technique to treat a cleft lip and palate, especially like me, if he is at the beginning of his career. When we think about the treatment of the cleft lip and palate, we have to go beyond the static aspect. During the last few years, you can see there was a huge changing of techniques when we are thinking about palatoplasty. For example, we went from simply closing the gap for now a complex reconstruction when we need to mobilize muscles and thinking about the real function of the palate, not only closing the gap. And not only the form is important, but also the function of this palate. And now I show you a picture like that. I ask you, what do you think about this image? For me, when I see a kid like that, she's a girl, the lip is almost perfect. The nose alignment is really nice. The nose shape is quite good. But this is my opinion. Maybe you are checking this picture and you have better cases than this one. You may say, oh, this car is not perfect. The lip could be better. The nose, it's not perfect. Why we have different opinions? Because the facial aesthetics is totally subject. And it's still a major challenge, not only for the surgeon, but for everyone, for the kid, for the family. And we know that if we have a poor outcome, mainly related with aesthetic, this kid could develop a behavior problem, social anxiety, and also depression. And maybe that's the most important thing, to have a nice team of psychologists dealing with families, with kids, and also with the professionals. Sometimes we do need it too. And the fact is that it can often be a challenge for the surgeon to choose this best technique to treat a cleft lip and palate, and how to choose the best technique and the right protocol. When we think about the treatment of the cleft lip and palate, we have to go beyond the aesthetic. We have to think that it's not only the surgery, is also the orthodontics intervention, is the speech therapy. We have to base ourselves on a large multicentric studies and on good and also bad experience that we find in the literature. A few years ago, it was really common that people would start their career treating cleft lip and palate with the experience of only one person or a small group. But nowadays, it's really easy to find information on the internet to check those good examples and also those bad examples. And maybe we could change our plans. We can adapt our protocols and start treating the patients that based on evidence, you know. For this reason, Centrinho, it's the hospital that I used to work, based itself to establish its protocol on the Eurocleft and the Americleft. More than 15 years ago, our hospital adopted a two-stage palate treatment for the treatment of unilateral cleft lip and palate. And based on that, the director was talking with me and he asked me, you know, we don't know how our cases are going. I mean, I operate some patients, but I don't know the global view of the hospital. So that's why I started this internal audit. The object was evaluate the statics result of 139 children who underwent this surgical protocol in Centrinho, Bauru. It's also called the Hospital of Reabilitação de Anomalias Craniofaciais. It was a retrospective study, and all the patients in our study underwent the same surgical protocol. Caloplasty and closure of the anterior palate were performed around 3 to 6 months, and after 1 year of age, palatoplasty was performed. Lip repair, we usually use Fisher technique, and anterior palate closure was the vomer flap, the Hans Pichler. In summary, all the patients were previously diagnosed with unilateral cleft lip and unilateral cleft lip and palate, no syndromes associated, no secondary lip and nasal repair. For example, all kids that had another surgery to correct the lip or the nose, they were excluded from our sample. And around 6 to 9 years of age at the mixed dentition, usually we take pictures of those patients. Honestly, almost every consultation that this patient has in our center, we take pictures of frontal view, of lateral view, sometimes intraoral view. So we have a nice documentation of those kids. And then at this age, at mixed dentition, around 6 and 9 years of age, we analyze those photos because we could have an idea about the facial growth, about the results of the lip, about the results of the palate, and also the function. But how did we evaluate these photos? As I told you, we try to go based on literature. We are based on a methodology already validated and used in previous studies. For those who doesn't know, it was the Asher-McDade criteria where photos are evaluated in frontal and side views. We were trying to exclude other parts that could identify the child to be a bias. And the parts evaluated were the nasal shape, the nose alignment, the vermilion border, and the profile view. Then we took all those pictures, like 139 pictures in frontal view, 139 pictures in lateral view, profile view, and we invited 3 surgeons with experience in the area of cleft lip and palate to evaluate all these photos at 2 different moments. So we evaluate, and after 30 days apart, we do it again. They would assign grades from 1 to 5, where 1 will be the best grade as excellent appearance, 2 good appearance, 3 fair appearance, 4 poor appearance, and 5 a very poor appearance. All data was analyzed by our team. They were tabulated and statistical analysis was carried out, evaluating intra and intercorrelation that was estimated by Kappa index. And about our results, evaluating our data, we saw that all the surgeries were performed by 9 surgeons from our service. The majority of patients were males, as expected for unilateral cleft lip and palate. The average age for caloplasty was around 4 months of age, and the average for palatoplasty around 18 months of age. And the pictures that we analyzed, the mean age of the study population was 6.29 years old. The intra-observer correlation was substantial, 0.62 according the kappa index, and the inter-observer was fair. But can you imagine, we're talking about 560 pictures, because like 140 pictures of frontal view, 140 pictures of profile view, and then another time. So the correlation was valid, and the inter-observer was 0.33. It's fair. And what about our scores? In this table, we can find the statistics results of each surgeon, and for each of the 4 parameters evaluated: the nasal shape, the nose alignment, the vermilion border, and the profile view. As you can see, we obtained a very homogeneous results, both for the surgeon and for each item evaluated. However, an interesting thing caught our attention. Here, you can see that the values, for example, our overall score was 2.34. For the surgeons, 2.45, 2.48. It varies from 2.12 to 2.49. In the literature, we discovered that one of the most important factors for a good surgical result is the surgeon's experience. And then of the 9 surgeons, 8 of them were considered senior surgeons, like they were dealing with patients with cleft lip and palate for over 10 years, for at least 10 years. But the best result, this one here, was the youngest surgeon at that time. He was working with people with cleft lip and palate for less than 2 years. And he was the only one who had results between 1 to 2. Oh, it means that it was almost perfect for vermilion border and also for profile veil. And that's an interesting fact that we found. And then I bring you back this picture. This is part of our sample. As I told you before, for me, it was almost perfect. And for the judge, they also said that it was almost perfect. Her grades were around 1.2, 1.3, something like this, about her nose shape, nose alignment, vermilion border. And one of our regrets is we didn't analyze the scar. So maybe if I would do this same evaluation again, I would add the scar, because it's an important thing for the patient, for the family. But why am I bringing back this picture again? Because as I told you, this is a nice picture of a child. I would be really glad if all my patients had this result. And I can bet that for almost everybody, they would be happy to have a result like that. And mainly if the kid is talking with a good speech, with a good voice, a good intelligibility, everybody will be really happy. But we are talking about one of the most important centers here in Brazil, Centrinho Bauru. And we already expected to have cases like that with a very nice result. But using the same technique by the same surgeons, we have cases like that. So, as you can see, we have a bad scar. The lip is not it is not good. The nose, the form is not that good. And the nose alignment, neither. So how? I ask you how? We have the same surgeons using the same protocols, and we have results like that and like that. And also like that. So I ask you, would the statics result really be a problem related to the surgical technique or the protocol? I have my guesses. Talking about poor statics is essential, but there are many other complications also related to the procedure. For example, fistulas. If you want to know a word that gives nightmare for the whole team, to the surgeon, for the parents, for the patients, especially the young surgeons like me, I would say that fistulas is one of them. And believe me, this is the most common complication with studies published on PubMed that varies from 0 to 77.8. Can you imagine? You have like 100 kids and only 23 kids, they were not diagnosed previously with fistulas. It's like mind-blowing. It's like absurd for me. But at the same time, you can find hospitals publishing that they had no fistulas at all. Is that real? I don't know. And we also know that in addition to being a nightmare for the surgeon, it can also be a nightmare for the patient, causing clinical symptoms, causing impairing speech, and problems with eating. So how did we analyze our fistula rates? I reviewed all the medical records, mainly evaluating the follow-up consultations with the surgeon, the speech therapy team. Furthermore, all patients who were described as having fistulas had intraoral photos checked. So I confirmed it with the photos of the palate, then I divided according to the size and to the location. The size was estimated by millimeters, and their location according to the Pittsburgh Fistula Classification System. For those who doesn't know the Pittsburgh classification, it's a well-known methodology. It's based on topographic distribution from posterior to anterior. Type 1 is in the uvular region, type 2, soft palate, type 3, junction, hard and soft palate, type 4, hard palate, type 5, junction, primary, secondary palate, and those here, type 6, type 7, they are considered sometimes intentional fistulas. They're anterior fistula, and they were not described at our study as it's a really uncommon thing to consider those in statistics of fistulas. And when we were reviewing the medical records, I was shocked. Why was I was shocked? Because I discovered that we had reports of 29 cases representing 21% of the sample. That's a lot. And excluding those anterior to the incisive foramen. And we had no difference between genders, female and male, they had similar rates. However, when we evaluate the evolution of different professionals, the records of different professionals, we noticed some divergence. Some did not consider fistulas when they were minimal and without symptoms, which were often just depressions. And sometimes with like this picture, it was written in one professional record that it was a fistula, but only one professional described that. When I checked the other surgeon who had the same evaluation, he said, no, there's no fistula. And then I checked the pictures and it was like this one, no communication, blind bottom. So others consider it and described fistulas as minimal and asymptomatic. Imagine how to describe a fistula measuring 1 millimeter. It's almost impossible. It's really hard to see 1 millimeter fistulas. And 1 millimeter fistula called as a minimal size with no symptoms. Is it really a fistula? So if we think about the gaps with communication that we can see and have problems, we only had 12 cases from 139. It represents something around 8.6 of real fistulas. And from those, we had 2 large fistulas, like huge, like almost 1 centimeter, 1.5 centimeters. Regarding the function of the palate, 79% were considered to have adequate function by the speech therapy team. 54 of them had normal voice intelligibility, and only 4 had severe intelligibility. Our results were based on reports of speech therapists identifying patients who had speech disorders affecting intelligibility and oral nasal resonance. At the same time, I don't know if you check Melissa, she's the head of a speech therapist in Centrinho Bauru. She was here a few months ago, and her team was before performing a well-designed and more accurate detail of this analysis, evaluating all the patients who had their voice recorded before. So if we compare our results right now, determining whether pharyngeal function is adequate as not or not, our results, they are similar to most centers. In the literature, if we check, the cases they have a rate up to 30% of velopharyngeal insufficiency. So it's really important that we notice we had a biases in our own institution regarding the definition of fistulas by professionals, which make us understand this broad aspect of results found in the literature. As I told you, if we search on PubMed, we can see results varying from 0 to 77. And in our center, some professionals said, oh, this kid has a fistula, it's minimal size, it's less than 1 millimeter. And the other one said, no, there's no fistula. And I also checked some cases that the patient was described having fistula, but there was no photos on the other record of the same professional, the fistula was not there anymore. So only one record was written. Maybe that's why we have this important variation between all those studies. And about the classification of fistulas, we were using maybe the most common system is the Pittsburgh, but we also can find embryological and morphological criteria. In our institution, we also had a system from Brosco, Dr. Thelma Brosco, that includes morphological criteria and presence of symptoms. Perialveolar fistula were considered as intentional residual alveolar cleft planned to be corrected at bone grafting age. Thus, they were excluded from our main results. Similar to other studies, our results show that the most frequent fistula location was the hard palate, Pittsburgh number 4, followed by the transition zone, type 3, but no sex difference were found. And now I ask you, what about the technique used in the second stage of palatoplasty? Would it be important to describe which one was used? Because as I told you at the beginning, we were using Fisher technique for the lip repair, but I didn't say which technique we were using for the palatoplasty. Our results. We know that, as showed in a meta-analysis, fistula rate vary only slightly between the different technique used for primary cleft palate repair. And over almost 55% of our kids, they underwent the von Longenbach technique, 33% the Summerlad, and around 12% the breastplate. And when we compare those techniques, there's not a huge difference between them. Our average was 68% when talking about velopharyngeal competency. And it was a bit better for Summerlad, 77, and a little less for von Longenbach, around 62, and 68 for breathweight. So, results suggest a favorable outcome for two-stage palate repair using the Vollmer flap, but it's the best technique to choose. So is the two-stage palate repair using the Vollmer flap the best technique? Unfortunately, it is not with this study that we'll have the answer, as we would need to have a control group and maybe take those two different groups and analyze it. The fact is that I don't bring this answer for you right now, but the importance of all of this that I've been talking for the last minute is that we understand that it's extremely important to evaluate our cases, whether as surgeon or as an institution, so that we can identify our problems and always seek improvements. As I told you, we work a lot. We know that it's not easy, mainly if you're working in an undeveloped country. We have to struggle with many problems. We have to do our best. Sometimes we lose a lot of time, even after the work, to trying to give the best for the patient. But we also need to take our time to check our results, to evaluate what we are really doing. If what we are doing is struggling ourselves to do the best, is it really the best for the patient? And that's exactly why auditing is extremely relevant in analyzing the quality of care. So of everything we talked about here, something I wanted to highlight is the importance of carrying out audits. Medicine today could not only be said like, oh, Dr. A is amazing, his results, they are the best. We cannot prove it. Like the center of Brazil had the best results. Why? No, just because everybody says that. No, it's not allowed to do this anymore. Medicine is based on evidence. And by analyzing our cases, carrying out audits, we can identify possible weakness and improve our performance, so we could give the best for those patients diagnosed with cleft lip and palate, sorry. Here, it's my email. If you have any doubts, if you have any questions, just say hello, and also my phone number. And thank you for your time.
Thank you, Dr. Feitosa. Fascinating. So you brought us through a lot of really in-depth technical data. For some of us, some of those graphs were a bit beyond what our normal range is. But I think you've landed us on a pretty interesting topic that is applicable in everywhere in terms of resource-constrained contexts, about how we examine the kind of work that we're doing in cleft palate repair, and then how we learn from this in terms of going forward. So this is the time, as Niti promised off the top, where we really give it over to you. There's a good group from around the world of different disciplines, including surgeons, who have been thinking about this topic, who have been really brought into this topic by your careful research, Dr. Feitosa. And so if you have a question or a comment that you'd like to make, feel free to use the chat button. Otherwise, you can raise your hand. We'd love you to turn your video on and ask Dr. Feitosa a question as well. And then beyond that, if you'd like to contribute in Spanish, again, feel free to ask your question in Spanish, and we have interpretation. If you came later, you want to make sure you hit that translate button and select English if that's what you prefer, so that someone can be able to ask the question in Spanish, and you'll hear that in your own in English at least. So thank you very much. So one of the questions that came up along the way was from Dr. Obadi. His question was, what are your comments on some of the post-operative factors that would cause a fistula? Dr. Feitosa, I'm not sure if you have some thoughts in terms of your research.
Well, can I answer?
Please.
I mean, it's a really common thing. The tension is the worst part for every surgeon. If sometimes we try not to do liberation of the palate, the lateral, and if you close with tension, probably you will not sleep well as a surgeon, because you may think that this could be the most important factor. But on the other hand, if you do more scars, probably you could have a problem with the facial growth. So you must balance. Should I do another scar and have a problem with the facial growth? Or should I let it on the limit to close this palate and avoid the situation of not having a fistula, you know, something like this? But another fact is the post-care. You give orientation for mothers, for fathers, and sometimes here mainly in Brazil, that some people, they have problems with the care. The kid does not have an assistance with health system. So the kid goes and puts something on his mouth, you don't pay attention, and he has a bleeding, and it takes so many days to go to the hospital. Sometimes he has to take long travels to go to the hospital. When you see the result, it's everything open it and something like this. But there are many factors. And sometimes, talking about my personal opinion, I do a surgery. For me, everything was perfect. And few weeks later, I see a fistula. I don't know why. Sometimes it's unclear for me. And I think for almost all surgeons, they don't know why they have. It was like a perfect surgery, no tension. The cleft was not so big, and we have a fistula. So the answer is there are many factors. There's not only one reason for that.
Thank you, Dr. Feitosa. And I appreciate both that balance of saying, okay, there's another surgery, might be more scarring, but also you're speaking to the reality of many people on the call that patients don't live next door to cleft palate repair hospitals. That often there is this sense of travel, additional costs, challenges in getting back, or even knowing they're welcome to get back. And I also appreciate your idea that there is some mystery involved, that even if you feel like you've done a perfect repair, that sometimes there's things that appear and it's not clear why. So I think this is a helpful framing for discussion. I see Suraj's hand up, so we'll go to Suraj in Chennai.
Hi, thank you. Thank you so much, Doctor. It was a wonderful presentation listening to you. I have two questions. I'm sorry, I'm driving. I have two quick questions to ask. One, do you recommend a graded approach or an algorithm to address fistula management? One. And number two, how much importance of having the orthodontist and speech therapist in the clinic to address fistula management?
I'm sorry, can you ask the second question again?
The second question is, how much, you would, as a surgeon, you would feel comfortable to have both the, not comfortable, important to have both the orthodontist and speech pathologist be there in the clinic for management of fistula, like how VP clinic will have more than one professional. I think in my recent experience, we have had, orthodontist and SLP and surgeon work together in planning fistula management. I would like to know your perspective on that.
Thank you, Dr. Suraj. So Dr. Feitosa, as we mentioned, we're a very diverse group on this call. How would you position the role of the team in terms of fistula management and the planning of it, please?
I'm really glad for your question, but honestly, I think the answer, we cannot think in another answer. It's fundamental, it's essential to work together. In Centrinho, Bauru, when the kid comes at the first time, we're all together at the same time, giving our thoughts, giving our opinion, giving our diagnosis for those patients. And this is so important for the patient, because we could discuss. Sometimes we, as surgeons, we think, oh, I think it's the right time to do the intervention. And then the orthodontic says, no, let me do something, let me prepare the patient, and then you operate it. If you take only your responsibility, you are doing a burden of care. You have the problem, will not have the best care. And speech therapists, for example, is like essential too, it's fundamental. Here in my reality, I was talking with you before. I was working in Bauru, like I told you, it's an important center here in Brazil. And now I came back to my hometown. It's a small town in the northeast of Brazil. And we are struggling with patients to treat. We have almost 500 children waiting for the first surgery. Some of them, they are like 6 years, 7 years of age. And imagine, we are talking about doing the first surgery. We don't have a speech therapist. So we close the gap and we pray, because this kid has to learn by itself. And you cannot even imagine about orthodontics. If this kid needs orthodontic surgery, it's almost impossible. Like a rhinoplasty is not the reality. And this probably is the same cases as in half of the world, We have really bad problems trying to work with kids with cleft lip and palates. And this is a challenge for everybody. And maybe that's why this discussion here right now, this moment that we are taking, it's so important. As I told you, I was working in a hospital here in Fortaleza, and people with cleft lip and palate, they're not important at all for them, because it's more important to have an operation of an appendicitis or transplant or a critical care patient. And so they are postponing all the treatment, and we cannot form a group like of orthodontics, of speech therapists, because of many factors. And then we are saved here in our city because of groups that sometimes they work with Smile Train partnership with the Operation Smile. Otherwise, we cannot do many things. But getting back to your answer, it's not even a question. I mean, it's essential. You cannot work alone. You have to work with a team of orthodontics, of psychologists. It's really important too, of speech therapists. And then you can work with those kids. Otherwise, you will not do many things. Just close the gap is not the most important thing for this kid.
Thank you, Dr. Feitosa. And yes, I think you more than half of this call, definitely, these challenges of a lack of adequate team members, available team members, and the priority of that is a huge challenge. We'll go to Ethiopia, Dr. McConnon, who has had the benefit of working with a speech therapist and an orthodontist for quite some time. Dr. McConnon, what's your question?
Yeah, thank you very much. It was a really very interesting talk. Thank you. The work is excellent. My question is just, I'm sorry if I was in between interrupted, if I missed your talk, but I just interested in how is the mid-face growth, because you are doing a vomer flap. A two-stage surgery was, I think, done. It was under review in Scandinavia. They are doing lip and soft palate. This is to get a good facial growth, at the same time also to get a good speech. But yours is, everything is anterior. Does has any effect on the mid-face growth?
Oh, thank you for the question. And hello from Brazil. The same sample is evaluated by my team for the speech therapist, talking about the speech, and the orthodontics team. They're evaluating at this age of mixed dentition. Nowadays, those kids are around 13, 14 years old. And during the analysis, the orthodontics team was also analyzing the bite and the mid-face growth. And I don't have the exact result, but they were quite good. At those pictures of facial growth involving statics, we could only use the profile view, as I showed you before, and they're between 2 to 3 on the grades that we adopted. 1 the best, 5 the worst. So that's an average. It's quite good. It's like 2.4, 2.3, and it's a good number. It's like similar with other techniques, because a lot of people, they used to say that if you operate the anterior palate at the beginning of, like, when the kid is 3-4 months, it could develop a problem with the facial growth. But our study didn't show that. I mean, the facial growth is quite good. And that's bringing another question, doctor. And that's bring another question. So in my opinion, and I think you are also a surgeon, I heard you talking, the best result is not related with the technique, but the surgeon. I don't know if you agree with that. If you are using another technique, you have a more experience, probably you have better results than I do, because experience counts a lot. Even with that result that the young surgeon had good results, I'm pretty sure that experience is one of the most important things on cleft lip and palate surgery.
Thank you, Dr. Feitosa. Yeah, an excellent point. We have an overall question, and then we'll jump into Dr. Siddhartha has a question from Kolkata. But the overall question that came up for me a few times in the chat along the way, and Jalexis mentioned this as well. Tell us a little bit about that process of surgeons, openly discussing some of these issues like fistulas, and how you create a culture where you're able to learn from each other and analyze and say, okay, this is happening. How do we figure out where we go from here?
That's exactly the problem that I found. We usually don't discuss about it. Even if you are working in an important center, you are working alone when we are talking about surgery. We work with like I told you, with the orthodontics, with the psychologists, with the speech therapist. But this is one group. Another group with another surgeon, usually they don't talk about it. They don't compare their results. They don't know what the other one is doing, you know? So sometimes their protocols are different at the same institution. Well, okay, I will have a fistula. When is the best time to approach this fistula? We don't have this. And that's exactly the problem, because we are working together, but the reality is we are not together, you know? So we need to establish protocols to do that and try to find the best way to work with those fistulas. And the reality is we don't have this protocol.
Thank you. Helpful. There's a specific question, if I scroll back up a little bit, from Kolkata around what is the incidence of fistula with regard to moderate or severe palatal index in your study or at your center in your experience?
Oh, in my experience, I'm a young surgeon. I mean, I graduated 1 year and a half, 1 year, almost 2 years. So I've been working. I don't have a lot of experience with, thanks God, I don't have a lot of experience with huge fistulas. But in that case, we found only 2 cases of moderate to severe, 2 cases from 139 kids. I think it's a good number compared with other huge institutions, important institutions around the world.
Thank you, Dr. Feitosa. So for me, one question that comes up as a non-surgeon is, you know, we know that in low and middle income countries, NGOs are one of the primary ways that patients have access to surgeries. And one of the primary ways that surgeries are assessed are with before and after photos. Tell me about how easy it is to talk about fistulas if our primary assessment is before and after photos.
Honestly, we don't use it. I mean, no one publish like before and after fistulas here. Talking about results, it's a new thing here in Brazil. It was forbidden for us to use any before and after surgery, you know. And last week we had this change that now we can publish things like that for scientific reasons or for marketing, like plastic surgery or something like this. But fistulas, it's a forbidden word for almost everybody. We only discuss when we are in the scientific group.
Interesting. Anyone else in your context? I mean, how do we move then towards, as Dr. Feitosa is letting us know, about going from fistula being a word that's not mentioned other than specifically in a scientific domain into something that can be an opportunity for learning and growth as our centers around the world grow? I guess that's a big question, not necessarily for you, but for anybody on the call who has a comment or a question. That's something I'm thinking about right now in listening to this discussion. Dr. McConnell, do you have another comment? Please, go ahead.
Comment or a question maybe. I think the commonest place for many surgeons for fistula is at the junction, hard palate and soft palate. But yours is, if I've understood correctly, it's a hard palate. Any reason for that? I don't know. Any explanation?
I don't know the answer, honestly. But I would like to ask you, I'm pretty sure you have a lot of experience on cleft lip and palate treatment. I would like to ask you your experience when treating those fistulas. When you find a patient with fistula, do you wait a specific time to operate them? Because we are changing like knowledge. I mean, I would like to learn a little bit too, if you allow me to do it.
Fantastic. So that's a question not just to Dr. McConnell, but to any surgeons. There's a number on the call from UK, from throughout Africa, from India. What would you say to Dr. Feitosa's question?
Yeah, my opinion? There is a saying that once there is a fistula, maybe having another fistula may reach to even 100%. So dealing with fistula, you have to be very, very careful. Here, we never touch a patient before 3 months minimum to deal with fistula. We wait 6 months, a minimum of 3 months before starting to deal with fistula. That is a protocol we are trying to stick to. But fistula is really a very difficult thing to deal, and having a recurrence is a very high percent.
Thank you. And may I ask you another thing? I mean, I have
Yeah.
a challenge here in Brazil. For example, we have almost 500 children waiting for the first surgery. And when I operate one kid, and if the kid develops a fistula, will you operate this fistula or give an opportunity to operate this other kid that's waiting and she's already 6 years, 5 years old?
What a question. So this is for the whole group. If in those places where, distressingly is common, there's a huge backlog for primary repairs, how do you triage between addressing a fistula and inviting a family who's been desperately waiting for a primary surgery to move forward with your limited OR time?
I can speak also. I think many things should be considered. The age of the patient you operated, who was injured in fistula, and the site of the fistula. If the site of the fistula is anterior, usually they say that anterior part of the fistula didn't really interfere with speech, so you can keep him. You can wait, and you can deal with those who are not operated. But if the fistula is posterior and the child age is critical age, I think you have to find some way to choose upon these patients. But if the fistula is anterior and the child age is like beyond what we call is critical age, then I think it's better to give priority for those who are not operated.
Thank you, Dr. McConnon. So a complex way of weighing these different these different needs that are there. Dr. Feitosa, there's a quick question from Dr. Bajoy around fistula rates and what you found in terms of ICP, isolated cleft palate or the different types of cleft. Do you have any comments about that?
What's the question again, please?
Sorry, the question from Dr. Bajoy is, did you find any difference in fistula rate between isolated cleft palate or U-clap or, just the different types of cleft?
No, we were only analyzing unilateral cleft lip and palate with no syndromes. It's a specific group. We didn't evaluate like bilateral and people with other comorbidities.
Thank you. That's helpful. Anyone else we haven't heard from yet? We've got a couple minutes left. What comment or question would you have? This is a pretty impactful discussion about all of us in terms of our commitment to comprehensive cleft care. As Dr. Feitosa has mentioned, it has impact on every discipline, how fistulas are managed and how they're addressed.
Dr. Siddhartha said priority for the primary repair, and I agree. I mean, it's a challenge for us surgeons to decide, well, should I give a proper treatment and goes back to this patient and treat his fistula, or try to give another chance for another kid? This is my opinion too, Dr. Siddhartha, but it's always a challenge because you may think, should I give the proper treatment for this first kid or should I give another chance for the other kid? It's not easy, but I agree with you.
I'll also draw your attention to Dr. Matt Fell from the UK, who's published a couple links, very helpful, about fistula management based on size and position. So there is some research out there that can be thought about and discussed within your teams as you think about this complex challenge of fistula management. Thank you, Matt. I don't know, Matt, if you have any other comments to share in terms of what you're thinking about this, please.
Thanks, Hugh. Yes, sorry, we're mid-lunch here, so there's a bit of a busy office, but yeah, it's been a fantastic discussion. Thanks for having us along.
Thank you. And so we will make this recording available, and you can follow through on some of these links that we can put into the comment section. These are all evidence that's been published. It needs to be discussed, though, to really have an impact on how our teams move forward. And we're really grateful today to Dr. Feitosa for leading us through, a really in-depth study. Again, really benefiting from the advantage of Bauru in Brazil and the experienced professionals there, and just having so many cases to choose from, and having everyone willing to participate in the analysis of their work. That's a really amazing asset. And then to have your study of this and presenting it in such an even-handed way, Dr. Leonardo, is really impressive, and we're grateful for that. I see that the time is almost there. Niti, do you want to take us through where we can go from here?
Yeah, thank you so much, Dr. Feitosa, for a very insightful and informative presentation. We'd love to hear from all those who have been here at this discussion, even post this webinar. What is that one idea that has been eye-opening or compelling for you that you would like to take away from today's discussion? And how do you hope to apply this within your own clinical setting or with your team, and what will be your immediate next step? So just as you think through these, through the webinar discussion, think through what you've just heard, please tell us more about this.
The takeaway that I would say for everybody, as surgeon, as orthodontic, as institution, check your cases. Don't just keep treating and thinking that you are doing the right thing if you don't have the real numbers. And avoid bias, do like evidence-based medicine, take validated methodologies and evaluate those cases. Then you could find sometimes problems that is, like we say here in Brazil, on your nose, and you can't see it. So review your cases. Yeah, review your cases. Try to find your weakness, because we're not perfect. And even if you are a good institution, a reference institution, you probably could have a lot of problems that you don't know. You just need to check this out, and then you could give the best treatment for your patient.
What a great wrap up, Dr. Feitosa. Thank you. And we would invite you to, for those of us who have partnerships with some of the NGOs and who are sponsoring the COCP or even beyond, this is a great discussion to invite us into. How can we be part of this journey towards learning from our approach so that we see children overcoming the limitations of clefts, including fistulas along the way? So thank you for such a thoughtful presentation. Thank you, everyone, for joining us. It's been delightful to be together. The hour is finished. Niti, if we want to share this discussion with some people on our team who maybe missed it today, how can we go about doing that?
So you can definitely access all of our webinars, including this one. So the recording of all of our webinars will be on our YouTube channel, the Circle of Cleft Professionals. We will be posting this webinar as well very soon. You can also follow us on Twitter or X. Our handle is @CleftCircle. And if you have any suggestions for webinar topics, presenters, any queries, or else would like to share any articles or other materials for our website, please write into us at info@cleftcircle.org.
Thanks, everybody.